I'm Jim Ron, and I work in the cardiac surgery ICU at Brigham and Women's Hospital, where I have an interest in outcomes and in blood transfusion in particular. I have no conflicts to report. Anemia, as we all know, is associated with poor clinical outcomes. But there is very little definitive evidence that blood transfusion is safe and effective therapy for anemia when standard transfusion thresholds are used. I hope over the course of the talk to convince you of this. The STS workforce on perioperative blood transfusion and blood conservation in cardiac surgery produced a set of guidelines for blood conservation in cardiac surgery in 2006 and updated it in 2011. And their primary conclusion with respect to blood transfusion is that a great deal is known with regard to blood transfusion risks, yet little is known of its benefits. The risks have generally been categorized as infectious, immunologic. This includes a pro-inflammatory state as well as an immunosuppressive state, other morbidity and mortality. Historically, we have underrated the magnitude of the risks associated with transfusion. This is a post-operative cardiac surgery patient who was bleeding profusely and received a significant number of blood products. This report from 2012 in Annals of Internal Medicine attempts to put the risks of blood transfusion in perspective. Historically, when we have discussed the risks of blood transfusion with patients in particular, we tend to highlight the very rare events, which include infectious complications and fatal hemolytic complications, which, as you can see, is roughly comparable to the risk of being struck by lightning. The risks of transfusion-associated lung injury or transfusion-associated circulatory overload are significantly greater. And as I hope to show later, this graphic really fails to include the morbidity and mortality that can be associated with infectious and ischemic complications that are associated with blood transfusion. With respect to trolley in particular, a study from anesthesiology suggested that the incidence of trolley may be 100-fold greater than previous estimates, and maybe as high as 4% in patients who are receiving 3 to 4 units of packed red blood cells. Transfusions in the ICU have been linked to an increased risk of infection, an increased incidence of reintubation, intubation time, and adult respiratory distress syndrome, post-bypass myocardial ischemia, left ventricular dysfunction, and atrial arrhythmias, as well as renal failure and stroke. Transfusions are also associated with an increased risk of mortality. Blood transfusions appear to be pro-inflammatory, they appear to be immunosuppressive, and they do not appear to significantly improve oxygen delivery to tissues acutely following a transfusion. The value of restrictive transfusion strategies was suggested by the TRICK trial. This is a landmark trial that was published in 1999 and involved 800 ICU patients in Canadian ICUs. The TRICK trial randomized patients into two groups based on transfusion strategies. The liberal strategy transfused patients whenever their hemoglobin dropped below 10 grams per deciliter, or roughly 30% for hematocrit. And the restrictive strategy transfused patients only if their hemoglobin dropped to under 7, corresponding to a hematocrit of roughly 21%. When all patients were analyzed postoperatively, there was a trend towards improved survival in the patients assigned to the restrictive transfusion strategy group. In the subgroup analysis, patients who were not as critically ill as measured by the Apache 2 score had a statistically significant improvement in survival in the restrictive transfusion strategy group. Similarly, patients who are younger than 55 years also had a statistically significant improvement in survival if they belong to the restrictive transfusion strategy group. Following the TRICK trial, there were a tremendous number of retrospective studies that found a significant correlation between adverse outcomes and blood transfusion. This study from 2014 in the Annals of Thoracic Surgery showed a significant increased risk of tumor recurrence in patients who underwent resections for lung cancer. The Cleveland Clinic Division of Cardiac Surgery reported on their experience in coronary artery bypass grafting patients in 2006 and found that red blood cell transfusions were associated in a dose-dependent manner with an increase in postoperative morbidity and mortality. The morbidity included serious infections, renal failure, neurologic complications, respiratory insufficiency. The association remained strong even after adjusting for risk factors known to be associated with adverse outcomes after coronary artery bypass grafting, and in every logistic model, the transfusion of blood was the most reliable predictor associated with adverse outcomes. This graph illustrates the dose-dependent relationship between red blood cell transfusion and adverse events. The x-axis here goes up to 10 units, and you can see that as more blood is transfused, the risk of mortality, renal failure, prolonged intubation, serious infections, myocardial infarction, and stroke were all increased in a dose-dependent manner. This is a 10-year review of the relationship between blood transfusion and survival in coronary artery bypass grafting patients. And you can see here that this curve represents the survival of patients who received no blood transfusions during their hospitalization for cardiac surgery, but that there was a durable negative impact on survival that was dependent, at least in part, on the number of blood transfusions that were provided during their hospitalization. Gavin Murphy and colleagues used the United Kingdom Population Register to evaluate the impact of blood transfusion during cardiac surgery and postoperative morbidity and mortality. And similar to the Cleveland Clinic experience, they found a strong association with both infection and ischemic postoperative morbidity, hospital stay, increased early and late mortality, and hospital costs with red blood cell transfusion. And when they divided their population into patients who received red blood cells during cardiac surgery and compared them with those who did not, there was a significant difference in survival that seemed to persist over time. The negative impact of red blood cell transfusion did seem to be independent of the nadir hematocrit experienced by the patients. The thing that is most striking to me about reviewing this data is the significant differences in all groups between infectious complications in patients who are not transfused, which range between 2 and 4%, compared to those who were transfused, where the percentage of significant complications ranged between 11 and 14%. Similarly, ischemic complications, which included stroke, renal failure, and myocardial infarction, ranged in the no transfusion group from 2 to 4%. And in those undergoing red blood cell transfusion, ranged between 12 and 17%. The membership of the Michigan Society of Thoracic and Cardiovascular Surgeons looked at 23,000 consecutive patients who underwent isolated CABG between January of 2008 and December of 2011 in Michigan. After excluding 6,000 patients who received 3 or more units of packed red blood cells, they compared patients who received no blood perioperatively with those who received 1 or 2 units. And the results were rather striking. There was an increased odds ratio of 2.4 for mortality when which was highly significant when comparing patients who received no blood compared with those who did. They also found highly statistically significant associations between blood transfusion and other adverse outcomes. And these included an increased risk of stroke, of renal failure, atrial fibrillation, time on the ventilator, reoperation for bleeding, need for dialysis, time in the ICU, increase in postoperative length of stay, and a decreased likelihood of being discharged home. There has been a lot of concern about how to appropriately treat patients with acute coronary syndrome. And it has been difficult to perform studies with this group of patients. Attempting to replicate the trick trial parameters. The retrospective analyses, however, suggest that within the transfusion thresholds that are typically used during percutaneous interventions, that there appears to be no benefit from providing blood acutely, and there's a strong association with adverse outcomes, including death and myocardial infarction. This study evaluated 24,000 enrollees in 3 large international percutaneous intervention trials. And patients were grouped as to whether or not they were transfused. 10% received at least 1 blood transfusion. And those who received blood were significantly more likely to die and significantly more likely to undergo experience a myocardial infarction. So this basically represents this in tabular form, and patients who underwent transfusion had a significantly higher rate of death and myocardial infarction, and in particular the composite outcome, which was a combination of death and or myocardial infarction. And here are the Kaplan-Meier estimates of 30-day mortality among patients who did or did not receive blood transfusions. In this study, there were an insignificant number of patients who were not transfused for a hematocrit less than 25%. The transfusion of stored allogeneic red blood cells does not appear to acutely augment tissue oxygen delivery. This is suggested by the increase in ischemic complications that has been seen in the studies just discussed. In sepsis studies, red blood cell transfusion is associated with increased calculated delivery but not consumption. Lactating mucosal pH do not improve with transfusion. And as mentioned previously, transfusion is associated with an increase in ischemic complications. This is a study from 1993 when septic patients in the ICU were transfused 3 units of packed red blood cells, and gastric intramucosal pH measurements were made before and after transfusion. There was no increase in systemic oxygen uptake measured in any of the patients studied for up to 6 hours post-transfusion. The calculated systemic oxygen uptake increased in parallel with oxygen delivery in all patients. There was an inverse association between the change in gastric pH and the age of the transfused blood. And in those patients receiving blood that had been stored for more than 15 days, the gastric intramucosal pH consistently decreased following red blood cell transfusion. So these authors concluded that they failed to demonstrate a beneficial effect of red blood cell transfusion on measured systemic oxygen uptake in patients with sepsis. And patients receiving old blood developed evidence of splanchnic ischemia. The possible mechanisms that could contribute to ischemic complications following red blood cells include decreased 2,3-DPG. This would increase the avidity of hemoglobin for oxygen and reduce the ability of transfused red blood cells to deliver oxygen to tissues. Decreased red blood cell deformability could cause sludging at the capillary level and compromise oxygen delivery. Stored red blood cells are deficient in nitric oxide and, in fact, can scavenge nitric oxide at the capillary level. And this may further contribute to end-organ ischemia. Transfusion of red blood cells is also associated with an increase in catalytic iron, which is released by the transfused cells, which, because of storage defects, are more fragile. Our institution investigated the relationship between bypass, blood transfusion, plasma catalytic iron, and renal failure in our population of cardiac surgery patients. We found that plasma catalytic iron levels rose significantly at the end of cardiopulmonary bypass and was directly associated with bypass time and the number of packed red blood cell transfusions. The patients with the highest serum levels of catalytic iron had a significantly increased risk of acute kidney injury, hospital mortality, and postoperative myocardial injury. The conclusions of prospective randomized trials are not as strong in terms of establishing a relationship between blood cell transfusion and adverse outcomes. I think it's fair to generalize about the majority of these studies that have failed to see a difference in outcomes based on transfusion strategies. And This slide is a summary of some of the major large prospective randomized clinical trials on transfusion triggers, starting with the TRIC trial, which basically looked at triggers of hemoglobins of 7 and 10, and found overall that there was a trend towards improved survival in the restrictive group that did not reach statistical significance. The study in cardiac surgery patients by Hajar and colleagues compared triggers of 8 and 10 and did not find any statistical difference in endpoints that included 30-day mortality, cardiogenic shock, lung injury, or renal failure. Carson and colleagues, in looking at patients with undergoing repair of femur fractures, compared triggers of 8 and 10 and did not find any significance in terms of the composite endpoints, 60-day mortality, or a 60-day functional test. Villanueva and colleagues are the only group in this collection of studies that in fact found a improvement in 40-day survival in patients randomized to a restrictive strategy group. They used parameters of 7 and 9 for hemoglobin to randomize patients. And finally, Hoist and colleagues, in looking at sepsis, randomized between 7 and 9, and failed to find a difference in 90-day all-cause mortality. This is a meta-analysis of randomized trials looking at risks of infection following transfusion. And in this trial, serious infections were statistically significantly associated with a liberal transfusion strategy. This study, which was previously mentioned, looked at acute upper GI bleeding, and they enrolled 900 patients, and they found, as previously mentioned, that there was a statistically significant result when looking at 45-day survival. And these are the survival curves. This is the orthopedic surgery population that looked at transfusion thresholds of 10 and 8 and found no statistical, at least it's no statistically significant differences. Of note, the differences in hemoglobin that were achieved throughout the study just reached statistical significance. And when evaluating the amount of blood that were received by both groups, there was approximately almost 100 more units that was given prior to randomization to the restrictive strategy group. Overall, the total number of units units was 1/3 in the restrictive strategy group when compared to the liberal strategy group. There were significantly more units of red blood cells that were given for patients in the restrictive group secondary to symptoms. In both cases, there were a minority of patients who received no blood at all. In trying to understand the failure of randomized clinical trials to confirm the associations between adverse outcomes and blood transfusion that are seen in the retrospective analyses, I think it's important to realize that the trials which evaluate restrictive versus liberal transfusion strategies address the risks and benefits of transfusion indirectly. And in many of these trials, there are comparisons between patients who received blood and other patients who received a lot more blood. And the outcomes appear to differ more when they are adjusted for the number of blood transfusions rather than adjusted based on transfusion strategy. The TRACS trial, which looked at cardiac surgery patients, is an example of this. The thresholds for transfusion varied very little between the restrictive and the transfusion group. And as a result of both this narrow range and the fact that it was hard to maintain equipoise and not break protocol when clinicians felt that patients in the restrictive group needed blood, it was impossible to see a statistically significant difference in mean hemoglobin when comparing the groups assigned to either the liberal or the restrictive strategy. And I think that this is probably why there was no difference in outcomes seen between the two groups. Significantly, if the survival was stratified based on how many units of red blood cells were received by patients independent of their assignment to the liberal or restrictive group, there is a very strong correlation between the number of red blood cells transfused and the patient's risk of death, as can be seen in this Kaplan-Meier plot. In the lower versus higher hemoglobin threshold for transfusion in septic shock trial, again, there were no differences in outcomes seen between the liberal and the restrictive groups. In this case, there was a statistically significant difference between the hemoglobin achieved in the different groups. But in this case, the patients who received no blood in the restrictive group only represented 36% of the total. And the majority of patients in the restrictive group did in fact receive blood. So this, again, is a case of patients who received blood as treatment for septic shock compared to patients who received more blood for septic shock. Another reason that it may have been difficult to detect a difference in outcomes was the very high mortality in both groups, 43% in the restrictive group versus 45 in the liberal group. That difference was not statistically significant. And this is this data graphically. Gavin Murphy, whose retrospective analysis using the UK registry with colleagues performed a randomized trial for patients receiving blood after cardiac surgery. And this was a trial that, again, showed no significant differences in outcome. And in addition, there was a trend towards increased mortality in the restrictive group. This is another case where a minority of patients in the restrictive group received no blood intraoperatively. And again, represents a study in which patients in the restrictive group received at least a moderate amount of blood transfusions compared to a liberal group that received more. And I think it's unfortunate that the patients could not have been stratified in a way that made the differences in the amount of blood transfused more significant. There are a number of guidelines that are currently used to suggest transfusion thresholds in both critical care patients and other hospitalized patients. The most recent comes from the American Association of Blood Banks. These guidelines are based on the randomized controlled trials, which show that restrictive strategies and liberal strategies result, for the most part, in comparable outcomes. So on the basis of this, the AABB recommends using a restrictive hemoglobin transfusion threshold of 7 for hospitalized adult patients who are hemodynamically stable, including critically ill patients, but a hemoglobin transfusion threshold of 8 for patients undergoing orthopedic or cardiac surgery, and for those with underlying cardiovascular disease. The reason for these different thresholds is that the randomized controlled trials performed in the latter groups of patients used a hemoglobin transfusion threshold of 8 and not a threshold of 7. So the strength of the data behind this recommendation really has more to do, I believe, with a lack of equipoise on the part of the designers of these trials, who have a bias that patients with cardiovascular disease or who are elderly and undergoing hip procedures would be at too much risk if the trick trial parameters were used. The committee chose not to recommend for or against a liberal or restrictive transfusion threshold in patients with acute coronary syndrome. At the present time, the randomized control trials are just not there, although the retrospective data does suggest that blood transfusion is of no benefit in patients with acute coronary syndrome. There were a number of retrospective analyses that suggested that stored blood was associated with storage defects that increased over time. And the Cleveland Clinic published a paper showing that outcomes in patients receiving blood that was more than their average age of 14 days had worse outcomes following cardiac surgery than patients who received younger blood. Subsequent randomized trials failed to confirm this, so the official recommendation now is that patients should receive blood that is up to 42 days old, because these findings, as I mentioned, were not replicated in randomized controlled trials. Finally, consistent with previous guidelines, standard practice should be to initiate a transfusion with 1 unit of blood rather than 2 units. This table represents historical guidelines which, for the most part, do not differ from the current guidelines, although there were stronger recommendations associated with the use of blood transfusion in patients with acute coronary syndrome. In 2009, the American College of Critical Care Medicine and the Eastern Association for the Surgery of Trauma Practice Management Work Group came up with guidelines for use in adult trauma and critical care. They concluded that red cell transfusion was independently associated with nosocomial wound infection, pneumonia, and sepsis. It was also independently associated with multisystem organ failure and systemic inflammatory response syndrome, as well as acute lung injury and adult respiratory distress syndrome. They also highlighted studies that showed transfusion to be independently associated with increased ICU and hospital lengths of stay and increased complications and increased mortality. On the basis of existing data, they suggested restrictive strategies for stable non-bleeding patients, including those with coronary disease or those who had mechanical ventilation requirements or neurologic injury. They highlighted that in sepsis there was no evidence that transfusion improved oxygen delivery. They also believe that 2 units should not be routinely transfused when transfusion is indicated, but did advocate that patients with active coronary disease should be transfused for a higher threshold of 8 grams per deciliter. They also concluded that blood products should be given for a clinical indication and not to treat a number. This slide provides a little more detail. Because of the risk associated with blood transfusion, it is important for optimizing outcomes to minimize the need for blood transfusion. This can be done with a more judicious use of blood draws, attention to surgical technique, and avoiding unnecessary blood loss intraoperatively, adherence to guidelines both in and outside of the intensive care unit. And one way to think about this is to treat everyone like a Jehovah's Witness. The Cleveland Clinic published a paper in 2012 that looked at their Jehovah's Witness population, comparing 322 witnesses to almost 88,000 non-witnesses who underwent cardiac surgery at the Cleveland Clinic between 1983 and 2011. None of the witnesses received blood transfusions perioperatively. Impressively, a very high proportion of non-witnesses also did not receive blood transfusions. Across the board, Jehovah's Witnesses did better when compared with patients matched for morbidity. This included fewer myocardial infarctions, fewer re-ops for bleeding, fewer episodes of prolonged ventilation, a decreased ICU length of stay, and hospital length of stay. Their one-year survival was significantly better, but 20-year survival was comparable. Blood transfusion rates are declining in the United States as clinicians are adopting more restrictive transfusion strategies. In the last decade, the use of blood transfusion in the United States has decreased by over 30%. This is a paper from the Virginia Cardiac Surgery Quality Initiative, who looked at 14,000 patients between 2006 and 2010 who were stratified according to the implementation of transfusion guidelines. And by instituting guidelines and dramatically decreasing their use of blood transfusion, they were able to significantly improve outcomes and reduce costs. So it does appear as if this is, fortunately, the wave of the future. In summary, blood transfusions are associated with adverse outcomes. Current guidelines favor a restrictive transfusion strategy. Stored allogeneic red blood cells may not improve oxygen transport to tissues. And blood conservation strategies may be the most beneficial intervention. I have a few questions and answers. The transfusion requirements in critical care investigators, the TRIC trial, performed a randomized multicenter trial. Liberal and restrictive transfusion strategies utilized hemoglobin triggers of less than 12, less than 8, less than 10, less than 7, less than 12, less than 6, less than 10, less than 8, less than 12, or less than 7. The answer is B. The liberal group were transfused for hemoglobin less than 7, and the restricted group were transfused for liberal group were transfused for hemoglobins less than 10, and the restrictive group were transfused for hemoglobins less than 7. The transfusion requirements in critical care investigators found that patients randomized to a restrictive strategy A experienced improved survival, B experienced more ischemic complications, C experienced improved survival if more critically ill, D experienced improved survival if younger, or E experienced improved survival if older. The answer is D. They experienced improved survival if they were younger and randomized to a restrictive strategy. Blood transfusion is associated with A, an increased risk of infection, B, decreased survival, C, an increased risk of a myocardial infarction, D, an increased risk of lung injury, or E, all of the above. And the answer is E, all of the above.